Hello, good evening, everybody. I am Rahul Chobe from Rheumat TV. We are live now. I am handing over this session to Dr. Nilesh Patil. Over to you, Dr. Nilesh Patil.
Thank you, Rahul. Good evening, all. Hope everyone is doing fine. Yeah, I, Dr. Nilesh Patil, consultant rheumatologist at Sancheti Hospital. Welcome you all to the Rheumat TV. Yeah, so today's topic is really important and it is an interesting topic because the topic is actually lab testing in connective tissue diseases. So why this topic is important? Because in our day-to-day practice, we see so many general practitioners, orthopedicians and physicians. They are always confused when they see a patient with joint pains. So they are confused what test to order for. So today's discussion is in-depth discussion and what tests are required and how can we minimize the test. Generally we see so many patients, the patients come with so many tests. So we can curtail this series of tests by simply just focusing on one test at a time. So for the discussion, we have our expert, Dr. SANAT Pathak. Yes, hi, Dr. SANAT.
Hello.
So yes, Dr. SANAT is an astute clinician and avid reader, and who has done his post graduation from KM, and then he did his DM from Asia, the one of the most prestigious colleges, HGPGI, and under the guidance of Dr. Amita Agarwal and Dr. R.N. Mishra. So who are the stalwarts of rheumatology. Then he has also done MRCP, and he has wrote several papers with them in national and international journals. And so currently he is attached with KM Hospital and Sassoon General Hospital. And again, we have Dr. Ajit Nalavade sir with us for the panel. He is heading the Department of Rheumatology in Sancheti Hospital. And so he is one of the senior rheumatologists in Pune. So almost practicing for more than 10 years. And he has been involved in so many clinical trials and recently, and he's always been called for faculty in different conferences. So recently he has just completed World Rheumatology Forum. So welcome you, Nalavadi sir. And again we have Dr. Sandeep Kansurkar, young and talented rheumatologist who has just finished his rheumatology from HGPGI. So he was with Dr. SANAT only, and he recently joined Bharati Hospital. Yes. So let's discuss our today's very interesting topic, the lab testing in connective tissue diseases. So over to you, Dr. SANAT.
My request, everybody keep mute yourself.
Yes.
So that we can hear only Dr. SANAT.
Yes.
So I won't mute myself.
Hmm.
Okay. Yeah. Hi everyone. I'm SANAT. I'm already introduced. So I'm jumping directly to what I'm going to talk about, which is diagnostic tests and mainly their interpretation in connective tissue disease. So before we go to the test, let me talk a bit about what connective tissue disease really is. So it sounds like a very nebulous term. I mean, we think that sometimes I ask my residents, what do you think? And they say, maybe it's a CTD or maybe it's a connective tissue disease. It's a very, very vague terminology when used, but actually it's pretty specific. So connective tissue disease is not a cloud, it's just 6 diseases. Which are multisystem and autoimmune. So you have many autoimmune diseases which are not multisystem. So those do not form part of the CTDs. So these are the 6 diseases: rheumatoid arthritis, so Sjogren's, SLE, systemic sclerosis, and the 2 inflammatory myositis. These are discrete diseases, and plus then you have syndromes which have overlaps of features of one of the 2. So suppose you have features of SLE, systemic sclerosis, or dermatomyositis along with a particular antibody, then we call it mixed connective tissue disease. If we don't have that antibody and we have overlap of symptoms of, say, rheumatoid and myositis, or rheumatoid and SLE, we call it overlap. And if it is actually vague, if it is actually nebulous, then we can call it undifferentiated right at the start. I'm also going to hit upon testing for a different group of diseases which are also multisystem and autoimmune, but do not really fall under the spectrum of CTD, which are the vasculitis. Sorry. So a vasculitis is basically inflammation of the blood vessel, and because blood vessels supply everything in the body, they are present as multi-system diseases. And vasculitis are classified as large vessel like Takayasu arthritis or giant cell arthritis, medium vessel and small vessel, which involve the capillaries. And here is where antibody testing really matters, is in the small vessel, because they are associated with certain antibodies. The large and medium vessel vasculitis are usually not, right? When you have a suspected rheumatological illness, these are the kind of symptoms which are often protean, quite vague. You have a skin rash, you have joint pain, you have fever and been extensively worked up for infection, then you're not finding anything. You have certain organ manifestations, renal failure, cardiac failure, brain involvement, or you have lymphoid hyperplasia, lymphadenopathy, splenomegaly, etc. Then you would suspect a rheumatological or an autoimmune inflammatory illness. Why do you need to test in this? So what are the goals of your testing when you have a person with a suspected rheumatological illness? So we have a number of goals. The first one is to show that it is autoimmune. And what tells you that it is autoimmune, that your own immune system is acting against your own antibodies, is usually the presence of autoantibodies. So you have anti-nuclear antibodies, anti-neutrophilic cytoplasmic, and these I'll be discussing for the rest of this talk. So I'm not going to go into much detail right now. The second thing you want to see is how much inflammation there is, because most of these diseases are inflammatory. So you have erythrocyte sedimentation rate, CRP, serum ferritin, complement levels, which are raised as acute phase reactants, and these help you monitor to see how much inflammation has come down. So more than in the diagnosis, these help you monitor the patient as well. If you ask me, the most important set of investigations which actually influence treatment is to check what all organ is involved. And because these are multisystemic diseases, it doesn't really matter which diseases it is. Even if it is SLE, even if it is dermatomyositis, even if it is Sjogren's, if there is arthritis only and no organ involvement, the treatment more or less remains the same. However, if there is organ involvement, then treatment rapidly escalates. So if there's renal involvement, nephritis, diffuse alveolar hemorrhage, a myocarditis, or inflammatory myositis in the form of raised CK and EMG showing inflammation, then the treatment, the amount of immunosuppression really depends on what organs are involved. So if there is one group of investigations that really influence management, it is this. Then of course you start them often on immunosuppressant medications, and then you need to monitor them both for the treatment. So most of these medications we'll need to monitor hemogram, LFTs or RFTs, plus comorbidities. So these patients are on steroids, so they'll develop osteoporosis, they'll develop hyperglycemia, so we need to monitor that. We need to monitor anemia of chronic disease and other comorbidities that are expected with the disease itself. Right. So these are the goals of the tests, but I'm going to mainly focus on principles of what we test when we are testing for autoantibodies. So that is the first group on your left, the autoantibody testing, and what we do and how we do it, right? So the oldest methodology of doing an antibody test is a methodology called immunofluorescence. So suppose you have a cell, and suppose a patient's serum has anti-nuclear antibodies, right? So if you have a cell, if you put the patient's serum onto it, and the white ones are the anti-nuclear antibodies, they'll bind to the patient's nucleus, bind to the cell nucleus. If you then add antibodies which are labeled with a fluorescent probe, they will bind to these human antibodies. So these are anti-human immunoglobulin antibodies. So they'll bind to these antibodies. And because these are bound to the nucleus, this nucleus will fluoresce. right, when seen under a fluorescent microscope. So that's the very simple principle, that if the test serum has anti-nuclear antibodies, adding a fluorescent probe will make that nucleus fluoresce, right? So which cell would you use to look at anti-nuclear antibodies? So theoretically, you can use absolutely any nucleated cell. So you can use anything apart from an RBC, because RBC is not nucleated, or very superficial skin cells. But you usually end up using tissues which have a lot of nucleus, or which have cells crammed together. So what often was used in the past is a rodent liver. So the picture in the bottom shows you on the left a cross section of a rodent or a monkey liver, which are packed with cells. And so if a test serum has anti-nuclear antibodies, then the nuclei will shine. So on the picture on the right, you find that you find a faint outline of the cell in the background, but you find that the nuclei, the central circular portion, are fluorescing brightly. So then you get to know that the person from whom the test serum came has anti-nuclear antibodies, right? So what we use now, because we are interested mainly in the nucleus, so really, and we don't really want to take out rat livers much. That's not really pleasant work, clearly. So we use malignant cells, because malignant cells are mainly nuclei. I mean, we know that malignant cells have a high NC ratio, a nucleus to cytoplasmic ratio. The most of it is nucleus. They have just a thin rim of cytoplasm. So on the left, you see the spindle-shaped cells with large nuclei. And therefore, we are able to see the nuclei very clearly. So what is usually used are cells called HEP2, which are carcinoma cell lines of carcinoma cell line cells. And these then show up as immunofluorescence well. So this patient has anti-nuclear antibodies, right? But you can use this pattern, or you can use this principle to look for antibodies to anything, frankly. So suppose you want to look at ANCA. That's basically anti-neutrophil cytoplasmic antibodies. So you just look, put up a smear of human neutrophils, and then put the test serum, and then put the labeled probe, and then here you see that these are neutrophils, these are fluorescing. So there are antibodies which act against the cytoplasm and not the nucleus. So it's anti-neutrophil cytoplasmic antibodies, right? What do you think this is? This is a cut section of the stomach. This is the parietal cell layer. The parietal cells are fluorescing. So this test serum has anti-parietal cell antibodies. So that is often seen in pernicious anemia and other GI autoimmune diseases. So this principle can be used for autoantibodies across the spectrum. What we are mainly interested in is the ANA and ANCA, right? So when you ask for a ANA test by immunofluorescence, this is the kind of report that you'll get. You'll get an observed value that's either weak positive, strong positive, or whatever. You'll get a semi-quantitative kind of plus or triple plus measurement that is seen by the eye of the person who is reading. You'll get the dilution, which doesn't really matter, but it's a standard thing for most labs. It's usually 1:80 or 1:100. And what you also get importantly is a pattern. So here you're getting a pattern called speckled, right? So here, if you see in this picture, the nuclei fluorescing, so this person definitely has anti-nuclear antibodies. But you see that the nuclei are fluorescing cleanly. So this is a pattern called homogeneous. And it gives you a clue that the antibodies are against some antigen in the nucleus, which are evenly spread out against the nucleus, right? So what is evenly spread out against the nucleus is mainly double-stranded DNA or things associated with it, like histones. So you can make a calculated guess that if I have a pattern which is homogeneous, mostly I have anti-double-stranded DNA or anti-histone antibodies. Okay. In contrast, look at the picture on the right. you see that it's not homogeneous like the one on the left. It's speckled. You see tiny speckles, and the nucleoli are not involved, or the chromatin is not involved. So you have something which is discretely present in the nucleus. So it might be some enzyme complex, it might be the spliceosome, it might be something else. So then you have other clues about what it might be fluorescing. Here you have only the centromere. So if you count these dots, you find only 46 dots. So the antibody is attacking only the centromere. So this is the centromere pattern. Here you see only 2 or 3 discrete dots within the nucleus. So these are nucleoli. So this is the nucleolar pattern. Right? What do you see here? So these are the spindle-shaped cells. This is the actual cell. The nucleus, if you see in the center, is not actually fluorescing, whereas the cytoplasm is fluorescing. So does this person have an ANA? No, it's not an anti-nuclear antibody. But despite that, he has some autoimmunity. So he has autoimmunity to a cytoplasmic antigen. So if you ask, the ANA report will be negative, but now it is said that even if cytoplasmic fluorescence is positive, you need to report it. So there's now an international consensus on ANA patterns on the basis of what you see on Hep2 cells. You don't really need to go into the details of this, but why is this important? So why is this important is because certain immunofluorescence patterns have certain clinical correlates, and that's important to someone like us who is ordering it with something in mind, right? So like I said, if either there's a homogeneous or peripheral rim pattern, it's something which is diffusely spread again throughout the nucleus. So it's anti-double stranded DNA or anti-histone. And this correlates with SLE. So you think that this patient might have SLE. Of course, the other clinical features will help. If it's a speckle pattern, then the antibody which is most likely associated is either anti-SM or anti-RNP or anti-Rho or anti-La, etc. And this correlates with many, many diseases. So it could be Sjogren's syndrome, it could be systemic sclerosis, it could be myositis. If it is anti-centromere, that's very specific to a certain disease called limited cutaneous systemic sclerosis, which was earlier called CREST. And the nucleolar is not specific. It might be seen in SLE or Sjogren's or systemic sclerosis, etc. So that is the reason that you want the pattern, that you make a guess about what disease it is correlating with. The other methodology, which is more widely available than immunofluorescence, the immunofluorescence requires an immunofluorescence microscope. It requires a person to read it, and a person has to check the pattern. This is much more widely available across labs. Is if you look at it by ELISA. So what is ELISA? What you do in an ELISA, the principle again is that in the well you put the antigen that you are interested in. If you are interested in antibodies to double-stranded DNA, you ground up double-stranded DNA and coat it along the well. If you are interested in antibodies to centromeres, you ground up centromeres and coat it along the well. If you are interested in antibodies just to a nucleus ANA, then you coat up ground up the entire nucleus and you coat it against the well. Then you add the serum. And if the person's serum has antibodies to whatever you've coated against, so if you've coated double-stranded DNA and if the person's serum has antibodies to double-stranded DNA, then they will bind. Then instead of labeling it with a fluorescence probe, you label it with an enzyme. And what this enzyme can do is change a colorless substrate to a colorful substrate, right? So only the last step is really different. Two things are different. Here you are selecting which antigen to coat with. And again, you instead of a fluorescence, which is visually seen, you can measure this amount of color, right? So what this gives you is a titer. What you didn't have that in an immunofluorescence test, a titer, you do have that in an ELISA. So that is one of the main advantages. So this is the kind of a report that you'll see if you look for anti-double stranded DNA, so they've tested for anti-DS DNA, you'll get a titer, and then you have cutoffs, which wasn't the case in an immunofluorescence report. You didn't really have cutoffs. So you have negative, equivocal, or positive. So the main advantage here is that you can test for a specific autoantibody. There in immunofluorescence, you were only making a guess. You were only thinking that, okay, if it is homogeneous, it might be double-stranded DNA. Here, you are actually testing antibodies against the double-stranded DNA or against the histone. So you can test for a specific autoantibody with this. And also the presence of a titer tells you that when you're following up the patient, you might see that the titer increases or reduces. So the utility of that in the clinic, we'll talk about that later, but that what helps you in following up. So an immunofluorescence doesn't help you in following up. If it's positive once, it's going to be positive later, and an immunofluorescence test does not need to be repeated again. The third one, which is often also very commonly ordered first, is a test called immunoblot or line blot or just ANA blot. Right? The principle is like a Western blot. So what they'll do is take little blots of antigen and coat them along a strip, and you put on the patient's serum, and whichever antibody the patient's serum has will turn up with color. So here you have maybe 10 antigens, 13 antigens, 15 antigens. The commonly one used on the right, you see that you have strips of nucleosome, DNA, histone, SM, etc., etc. So here you know that if an ANA is positive, in one setting, you will come to know which antibodies they have. So some patients may have antibodies to both DNA, Rho, La, etc. all at once. So you'll get to that in one go. The problem with ordering this first is that you're restricting yourself to only these many antibodies. So the nucleus has many hundreds and thousands of antigens. It might be that a person's ANA might be targeting one of those antigens which are not present in these 13 or 15. And then you have the chance of missing that ANA. So that is the only danger of ordering this test first, right? So these are the three tests. When do you need an autoantibody in a CTD? So is this correct that if there is no antibody, it is not a connective tissue disease? Is this correct? So it is correct in very certain situations. So in these three diseases, without an ANA, you cannot label these three diseases. So if you're saying that a person has drug-induced lupus and an ANA is negative, it is not drug-induced lupus. It is a drug-induced rash, probably, or may not even be drug-induced. A mixed connective tissue disease is a serological diagnosis with the presence of an anti-RNP. So if you have an ANA negative, it cannot be an MCTD. Similarly, an autoimmune hepatitis is a hepatitis with an ANA positive with other things. So without an ANA, you cannot label a person as autoimmune hepatitis. So, but these are the only three places where it is absolutely essential. It is, of course, helpful in many other cases, like SLE, where 99 to 100%. So most patients will have ANA positive. So you need to really check yourself if you're diagnosing an SLE without an ANA. In the others, is much less common, or not as common, at least. Like in the myositis, maybe just about 50%. In Sjogren's syndrome, again, it may be between 50 to 75%. So here you're allowed to say that a person has Sjogren's syndrome without an ANA positive, but you need to keep this in mind when you're diagnosing it. But definitely, it's not sine qua non in all of these patients that you need to have an ANA positive, right? So we often get referrals saying that, you know, you have some features of many features of a connective tissue disease, but an ANA is negative. These patients flit around from here to there. Their diagnosis is delayed, and when you have reasonable evidence that there is an autoimmune attack on organs, they should be treated. So an ANA will only help you. It is not be all and end all in rheumatological diagnosis, right? Right. So let's see a person like in a clinical situation. Say you're trying to make a diagnosis of SLE and how an ANA will be helpful. So SLE, we know, is a multisystemic diseases. They can present with hematological, arthritis, rash, neurological, pulmonary, serological, everything under the sun they can present as, right? What additional information does an ANA or an antibody give you in this patient? Okay. So before we go there, I'll just be a little unpopular and just bring you back to these unfortunate terms from our PSM days. You remember sensitivity, specificity. Do you remember sensitivity and specificity? So just taken very simply, sensitivity is the ability of a test to correctly identify those with the disease. Specificity is the ability of the test to correctly identify those without the disease, right? So specificity rules out a certain diagnosis, sensitivity screens for a certain diagnosis, right? So if sensitivity is high, it's a good screening test. If specificity is high, it's good. So you can say that if certain person does not have this disease, right? And then you have these two terms called likelihood ratios. You have a positive and a negative likelihood ratio. These are formulae for it. I mean, they are available widely, so you don't really need to mark them up. But just as a clinical exercise, let's look at these values for two tests. Okay. In SLE, so they'll be different for every disease. So look at the sensitivity and specificity for ANA in SLE. So it's 93% sensitive, 57% specific. And with this, the positive likelihood ratio with these formulae I've calculated as 2.1 and 0.1, negative likelihood ratio and positive 0.1. So just remember these numbers because we'll be coming back to them. And let's take another test. So this ANA in SLE is by immunofluorescence. Anti-SM is a specific test. So the specificity is 95%, but the sensitivity is only 25%. It's not a sensitive test. And the likelihood ratios are 5 and 0.7. Okay. So just remember these two numbers, the 2.1 and 0.1 and 5 and 0.7. Okay. That helps you what additional information this test is going to give you when you're diagnosing a patient. Okay. So suppose you have this patient. This was a girl who was recently admitted with us in the pediatrics ward at the KEM. Classical butterfly rash. I mean, you don't really get to see this kind of butterfly rash anymore with textbook kind. Even from the door of the ward, you can sort of make out that there's a patient of SLE. Plus, she had arthritis, she had pleuritis, she had leukopenia, lymphopenia, and a nephritic sediment. So she had everything under the sun. Right. So now what I need to do to use this likelihood ratio is you get these kind of nomograms. They're readily available. Obviously, you don't need to use them often, but just to make a point, I'm going to try and use them from the start. So you need to have a pre-test probability in your mind of how likely you think this disease is. And then the test that you do will add to that pre-test probability through the likelihood ratio and give you a post-test probability, right? So what do you think is the pre-test probability in this patient? I would think that it would just about be 100%, right? I don't find any other diagnosis with such a classical malware rash, arthritis, pleuritis, everything, right? I mean, it's almost a certain diagnosis. So, but okay, chalo, we'll keep it as 95%, 5% we'll keep a chance of something else being there. So we take 95, and then now if we do an ANA by immunofluorescence, right? Remember the likelihood ratio, positive likelihood ratio? It was something around 2. So we draw a line from 95 to 2 and then extend it. And now the post-test probability is 98%. So it's almost certain that this patient has SLE, right? But what has this test really added? It's not added much. It's added just 3% if you look at it quantitatively. Your pre-test probability was already 95%. This $1,500 extra has given him just a 3% additional chance. So it's not really added much. If this was a very, very poor patient, I wouldn't even bother doing an ANA in her because it's not going to add much. But look at this other patient. This is a 15-year-old girl. She was admitted with only a 10 or 15-day history. She's come with erythematous rash, muscle pain, arthralgia, but no objective arthritis, fever, raised DSR, raised CRP, and serositis on abdominal USG. This could be SLE. I mean, if you look at it, it'll fit criteria, the SLIC criteria, the ACR criteria with serositis, arthralgia, etc. But this could also be many, many other things. So this could be just be a dengue. This could be any viral infection for that matter. It could be some other connective tissue disease, etc. So here, let's say that it is 50% SLE, 50% not SLE. Okay, so then we take the pre-test probability as 50%. Now here, if the ANA comes positive, through the 2, the post-test probability jumps by a good 20%. Right. So from 50, it goes up to 70%. So you're now much more certain than you were before the test that this is likely to be an SLE. But what is even more important is if the ANA comes negative. You remember the negative likelihood ratio? It was something like 0.16. So if the ANA comes negative, it goes down from 50 to somewhere around 5 or 7%. So that makes SLE very, very, very unlikely. So this is where a sensitive test really helps to rule out a diagnosis. So if it is negative, the likelihood of that disease is unusual. But if it is positive, it may be that disease. Okay. Now, suppose in this patient you've done an anti-SM directly. You have the ability to do an SM. You quoted the ELISA well already. So what will this test do? If it is positive, then that had a positive likelihood ratio of 5. So it'll bring up the post-test probability from 70 for an ANA by immunofluorescence to somewhere around 80. So not much change. But the problem is if it is negative, and if you remember, it was present in only in 25%. So if it is negative, then the negative likelihood ratio was 1. So from 50, it remains at 50. So that is the problem in using a specific test at screening, that the probability remains absolutely the same if it is negative. And that is just basically $2,000 down the drain. I mean, you've not done anything apart from spend money. But now, if you do an ANA first in this girl, from 50%, you've gone up to 70%. And now you know an ANA is positive. So then you want to check if it is an anti-SM, if it is an SLE. So now, if the ANA is already positive before you do an anti-SM, your pre-test probability is 70%. Right? So from 70% now, if that comes out to be positive, then you have a post-test probability of nearly 100%. So this is where a specific test will help if a screening test has already told you that it is probably that disease. So this was just an example of using it in the clinic. But if you look at all the guidelines that are available, you'll find many, many guidelines, pathology guidelines, rheumatology guidelines, etc. The principles are more or less the same. So if you want to do a test, if you're suspecting a disease that is associated with ANA, like lupus, then do an immunofluorescence, FANA is fluorescence ANA, or do a sensitive test first. If it is positive, then look at what manifestations the person has and then do a specific test for that particular disease. So if the ANA is positive and if the person has features suggestive of systemic sclerosis, then you'll only do an anti-SCL70 or an anti-U1RNP, etc. Then you don't need to do the entire spectrum. So you're reducing the test load also. So like for this patient, if you had everything, like you have arthritis, myositis, hematological, etc., etc., then an additional blood test is not going to help you much. But if you had only a couple of things, like if you have only arthritis, if you have only serositis, that is where it is going to help you. Okay. Second, this is the other question, that is the presence of one antibody associated with that particular disease only? Right. So I remember this same patient. We did an ANA. The immunofluorescence came out to be homogeneous. We did an ANA blot after that, and that showed double-stranded DNA and row 62 plus SM positive. So the next day when I went, the pediatrics resident had written SLE with Sjogren's syndrome on the file. And I was quite, I asked him, is there any clinical features of Sjogren's? Is there any Zika? Is there anything else? And he said no. But row 52 is positive, or row 60 is positive. So dsDNA is SLE, row is Sjogren's. So is that correct? That is not correct. So one antibody is not one disease. It's not the genetic code where one gene, one protein. It's an antibody. Many antibodies can be present in even a single disease. So overlaps are very often diagnosed, but they are often overdiagnosed just because of antibodies. So just the presence of two antibodies does not make this an overlap syndrome. As you can see, this is a table from Harrison's. Anti-Rho is present in 30% of SLE. Anti-La is present in 10% of SLE. So just because she is a Rho does not make an additional Sjogren's. Right. So often there is an overlapping phenotype within the diseases. So look at Rho, for example. So some antibodies are specific to certain diseases. So in the green, you will find that double-stranded DNA, SM, ribosomal P are not really associated with anything else. Rho and La are present in many diseases. So Rho is present in systemic sclerosis. It can be present in Sjogren's. It can be present in SLE. It can be present in myositis. So this is just a learning point to say that an antibody does not make a disease. The clinical features makes a disease. The antibodies are just supportive, right? So the other reason that you look at antibodies are because certain specific antibodies are associated with certain clinical phenotypes. So in inflammatory myositis, for example, you get panels now which look at myositis antibodies. If you see a patient with inflammatory myositis and if he has anti-MDA5 or anti-synthetase antibodies, that tells you that this patient might also get lung disease if she doesn't have it now. So you will screen better for that patient. So that helps in prognosis of the patient, right? So for example, if a person has this kind of rash with hematological, with this thing. Okay, so I'm not really going to go into these cases. Doesn't matter. Should I? Do we have time?
We have 15-20 minutes.
Okay. Fine. So then let's do these cases, no problem. Fine. So here was a patient, a 16-year-old girl. She had come to the pediatrics department at KM. She had presented with myositis, right? Basically, she had proximal muscle weakness, difficulty in getting up from the squatting position. Her CPK was raised. So she was already labeled dermatomyositis. We called in, and the only unusual part that was that she had leukopenia as well as thrombocytopenia, which is not a very common feature in dermatomyositis. Otherwise, everything was fitting. So that's why we said that we should do an ANA and look at other things also. So her ANA came out to be 4+ homogeneous, and anti-double stranded DNA came out to be more than 100, right? So this was an antibody pattern which looked like lupus more than dermatomyositis. Anti-double stranded DNA, as we just saw in the last slide, is more or less specific to lupus. So with a lot of fighting and arguing and coaxing, I tried to change the diagnosis from dermatomyositis to lupus with arthralgia, with myositis and cytopenia. She was already on steroid 1 milligram per kilogram, and azathioprine had been added. I made no change in disease, in the treatment. This was fine. Steroid 1 milligram per kg plus azathioprine. So despite all my tantrums in the pediatric ward, they were sort of laughing that, frankly, it's made no difference because it's only theoretical, all these antibodies, because the treatment has remained the same. What was the point of doing all of this? But if 6 months down the line, her muscle power rash, we kept monitoring her. What changed was that if we had labeled her as dermatomyositis, all we would have done is looked at the muscle power, checked the rash, done a CPK, done a hemogram. Now we were monitoring her as a lupus. So we also did blood pressure, we did systems evaluations, we did renal functions. And sure enough, about 6 months after, in fact, after her myositis component was settling, she got a new onset hypertension and nephritic sediment. And then she was done, a biopsy was done. She had class 4 nephritis, and she was given methylprednisolone pulses and cyclophosphamide. So if you go back, if I had not done the antibody then, she would have kept the label of dermatomyositis, and this monitoring would not have changed. And we would have completely missed him. The dermatomyositis patient, we're not really expecting anything. Like, we're not expecting nephritis to occur. So we would have completely missed this. And I mean, her kidneys would have been worse. So this is where it makes a difference, that antibodies tell you, even if it is not present now, what to expect, like what I said in the myositis antibodies. Right. So this was a patient that I saw in Sassoon, the Sassoon OPD, the general OPD. He had asymmetric polyarthritis. You can see his hand. He had nail involvement, and he had these classical psoriatic patches on the back. So what was the diagnosis? The clinical diagnosis was psoriatic arthritis, right? What test would you do? Like, what antibody would you do? Nothing. I would do nothing. Psoriatic arthritis is not a CTD. It's not associated with anything. If at all, just to fulfill criteria, one can do a rheumatoid factor, because psoriatic arthritis by criteria needs to be rheumatoid factor negative. But this is, in your face psoriatic arthritis with nail involvement and skin involvement. But what that patient came with a big report in a file, was a thing called an arthritis panel. So they had tested everything under the sun, and it came with a lot of red things, like underlying things. So rheumatoid factor was negative. ASO titer was a little more. I mean, the cutoff is 200. It was 220. Uric acid was 7, and psoriatic arthritis is known to have high uric acid because of the high turnover of the skin cells. CRP, ASR was of course high. Complements were raised, not low, because they are acute phase reactants. And ANA was some by ELISA was 1.6 with a cutoff of 1.4, unfortunately. And this is probably a false positive. But then what was treated before he came to us? So, I mean, I assume, because obviously no rationale of treatment is ever given. But before he came to us, he was on penicillin prophylaxis because of this anti-streptolysin O titer. He was on febuxostat, which is completely asymptomatic hyperuricemia. And he was on steroid, which in a psoriatic arthritis is actually harmful. It might increase, probably because of this ANA and C3, C4, which were underlying. So what was the disease? What is the clinical? This thing is completely ignored. The elephant in the room was not treated at all. What was treated was the report, and all in a fashion that is actually definitely not helpful and possibly harmful in the form of steroids. So that is what these arthritis panels do. If you test without a clinical diagnosis in mind, all it leads to confusion and unfortunate and unusual treatments. We are clearly not rational. We had done an audit when I was training. We looked at how rational we are in testing for anti-cytoplasmic and antibody in that particular hospital at SGPGI. So I had just looked at about 1,600 samples that was received in the immunology lab, and out of those 1,600, only 108, so 6.8% were positive. That's it. That's fine. I mean, ANCA vasculitis is not a common disease, so that's equivalent to anywhere else. But even out of these 108 patients with a positive ANCA, only 27 had ANCA-associated vasculitis. 81 had no ANCA-associated vasculitis. They had many, many other things. So in 81, there was a false positive. In 27, it was a true positive, which is quite dangerous actually, because look at these patients with the no ANCA vasculitis with the ANCA positive. 5 had tuberculosis. If we had given cyclophosphamide and steroids, then it would have just flared up. So things like that. So that is the problem, where if we order irrationally, the false positive rate goes up. So if a person has known tuberculosis or has CKD or has malignancy, where ANCA vasculitis is not really a concern, then all of this testing would have been saved. And so pre-test probability, as we said, should be high before we really test. Good, so I'll finish here. As I said, that we have a large armamentarium of antibodies, but the learning point was that we need to screen with a sensitive test, like if we are looking at an ANA disease, then by immunofluorescence, and confirm by a specific test. And the antibodies to a specific antigen tell you about a specific phenotype, like double-stranded DNA with the lupus phenotype, or nephritis, or many in the systemic sclerosis spectrum. And they might tell you prognosis also, like what happened in that girl. But one shouldn't test without clinical indications. All that adds is cost and confusion, like what was done with the arthritis panel patient. Thank you.
Thank you, Dr. SANAT, for simplifying such an intricate topic. So, I would like to request panel if you have any question for Dr. SANAT. But before that, I have 2 questions. First is the importance of HEP 2000 cell, which ordering ANA by HEP 2000 over HEP 2 cells. So, can you please throw some light on it?
As I said, I'll just stop sharing this. So as I said, the HEP cells are malignant cells. So we are looking at a large nucleus and seeing which antigen it is the antibodies are attaching to. The HEP 2000 was recently developed a decade ago. So what it additionally does is the problem of the anti-Rho antibody. It tries to solve that. So the Rho antigen is sometimes a cytoplasmic antigen, sometimes a nuclear antigen. So if you have a person with anti-Rho, you may miss it if it is in the cytoplasm.
Yes.
So what the HEP 2000 modification tries to do is put the Rho inside the cell, and therefore it will also fluoresce if it's got an anti-Rho. That's the main difference.
Okay, so I have a question for Dr. Nalawade. Yeah. So you have any question for Dr. SANAT, please?
Yeah. The ANA blot assays which we all order in many hospitals, are they different in different labs, or
it depends on the principle is the same. It depends on which all antigens they put on the blot strip. So you have antigen, you have 10 antigen, 15 antigen, you have myositis specific antigens, blots with those. So that increases or decreases sensitivity basically. So if you have 15 antigens, it will just increase the test sensitivity a bit than 10 antigens. That's more or less it.
Basically, all ANA blot assays are similar. Maybe
in principle they're the same. Yeah.
They're same. Okay.
So Dr. Sandeep, yes, I have a question for you. So since the topic is about myocyte specific antibodies, so can you just throw some light how they are important? Because up till now, the people they never used to send these myocyte specific antibodies. Can you just say something about it? Yeah, you have to unmute yourself.
Yeah, nowadays the use of myocyte-specific antibodies has been underlined again and again because it helps us to diagnose the involvement of organs other than muscles, which are quite often ignored. While we're able to diagnose the myositis, we tend to look at the muscles only. So certain antibodies are like MDF5 are associated with a predominant lung manufacture, which may get ignored during monitoring. So myocyte specific antibodies are useful nowadays. So if we don't have a clear-cut diagnosis like dermatomyositis, it's useful to use myositis specific antibody to categorize the myositis patient. Sure.
At the same time, about the prognosis of the patient, that which organs can get involved eventually in future.
Yeah. Yes.
Thank you. So, and Nalavadi sir, so can you just tell me how important is to ask HLA-B27 by PCR method over flow cytometry method?
Actually, it is more sensitive than flow cytometry. But you know, even in spondyloarthritis, the most important I would consider is still the clinical presentation and the X-ray findings. If you have sacroiliitis on X-rays, you don't need HLA-B27. It's a bit costly test, and really it doesn't help much to spend so much rather. So as against these autoimmune diseases like SLE, spondyloarthritis many times is straightforward diagnosis.
Yes. Dr. Sanat, yeah, if the patient is classic of, means the patient looks like typical of lupus and the patient's ANA is significantly positive with high titers, but ENA is negative and even the complement levels are normal. In that scenario, so what should I look for?
I mean, that's fine. As long as there's a clinical diagnosis of lupus and an ANA is positive, we are treating the organ manifestations. So I would just go ahead and start treatment according to which organs are involved.
So all in all, clinical acumen will always have an upper hand.
Yeah.
Yes.
I think Dr. Sanat can shed light on the certain conditions where we can get multiple autoantibodies positive. So,
right. So, I mean, most autoimmune diseases can have many antibodies. And if you remember that slide of mine where you have some antibodies which are present in nearly everything, which can be present in nearly everything like Rho or La. Plus, it has also been seen that you can have an increase in the number of antibody specificities as the disease progresses. So this is a phenomenon called epitope spreading. So where it starts off, a person might start off with only a double-stranded DNA positive, and then 10 years later may have 3 or 4 antibodies positive. So that is known. Plus, there are other differentials where you have false positive multiple antibodies. So something like where there's widespread immune involvement like lymphoma or immune proliferation like lymphoma or even HIV, you might get multiple antibodies positive. So, I mean, just a multiple antibody positive doesn't really get you a diagnosis.
Yeah.
I think the questions are over and we're already short of time. Yes. Thank you, Dr. Sanat, for such a wonderful talk.
Thank
Yeah,
you.
it's
My pleasure.
always a treat to listen to Sanat's talk.
Yeah.
We always miss him.
Thank you, Ajit
Yeah,
sir, and
yeah.
thank
Technical
you.
topic, very elusive.
Yeah, since seminar days, it has
Yes.
always been a pleasure to listen to him.
Thank you,
Yeah.
Nalavadi sir, and thank you, Sandeep, for
Okay.
being the
Thank you.
panelist. Yeah, I thank Sancheti Hospital and the Rheumat TV for giving us the opportunity. Yeah, thank you, Dr. Ashok Sham and Rahul sir, for the back-end support. Thank you.
Thank you.
Okay, thank you. Thank you
Okay.
very much. Okay, bye.
Take care. Yeah.